In this section, I'd like to discuss rising costs and national medical care systems. So here, I'd like to look at what causes the U.S. medical care system and that of most other developed countries to be quite expensive and to rise in cost as time goes on. The United States has, compared to many other countries, an unusually expensive medical care system. We'll address that in the next section. Here, I'd like to look at some of the factors that have contributed to rising medical care costs here in the U.S. Vijay Boyapati points out that employer-provided health insurance is one of the keys to understanding this. Toward the end of World War II, income tax rates were very high in the United States, over 90%. And so employers were looking for ways to provide their employees with a benefit that would not be taxable. And one of those benefits was health insurance. So starting in 1943, employers began to provide more and more of this health insurance to escape the very high income taxes being imposed on their employees. And we've seen that just grow and develop ever since. Medical licensure, which we discussed in an earlier segment, has contributed to rising costs by limiting the number of medical professionals in the economy, driving up prices by reducing supply. Third, the obesity epidemic may be a large part of our rising costs, as that contributes to a number of health problems, some of which are very expensive. And then we've already discussed intellectual property and patents as a part of that rising cost in the United States. Foy, Schiamana, Kozak, and Filipponi say that in the 1980s, the conventional explanation of healthcare cost growth emphasized the moral hazard from health insurance, and particularly the tax treatment of health insurance. Just what we've just discussed about employers trying to allow a compensation of some form that's not going to be taxed as heavily as cash income would be taxed. The authors go on to say that insurance drives the marginal price of medical care at the point of use to near zero, so rationally, consumers or physicians acting as their agents demand care until the marginal product of additional care is nearly zero. In other words, if it's not going to cost you anything, why not use more of it? Empirical evidence does exist in support of that conventional view. Studies have found that a fully insured population spends about 40 to 50% more than a population with a large deductible, and their status is not measurably improved by the additional services. This has been referred to by Enthoven as flat-of-the-curve medicine, where spending on medical care increases even though additional gains from such spending are very low or non-existent. We've already referred in an earlier segment to the Oregon experiment, where we found that Medicaid coverage generated no significant improvements in health outcomes in the first 2 years, despite increased use of medical services, increased use of prescription drugs, office visits, preventive care, including mammograms, and annual spending per individual by insurance plan in excess of $1,100. The conventional view was challenged by Newhouse, who argued that the bulk of healthcare cost growth is attributable to technological change, or what he says might loosely be called the march of science and the increased capabilities of medicine. According to this view, if you have more medical spending, then you should get increased welfare. Newhouse acknowledged that there was some validity to the conventional view about moral hazard when looked at over a single period, but said it was insufficient to explain healthcare cost growth over time. And he was dismissive of the idea that increased insurance could lead to too much technological change. If technological change did increase welfare, he said, then countries that make centralized decisions about how much to spend on medical care wouldn't adopt certain changes, so their healthcare cost growth would be less than the U.S. But since their cost growth is similar, he said, technological change must enhance welfare. So the authors of this study that I'm quoting here said that Newhouse was incorrect to dismiss that idea that too much insurance could lead to too much technological change. In fact, it is possible for there to be too much technology in medicine. Not that we should be anti-technology per se, but if you have more technology growth without a corresponding benefit in health outcomes, then you've spent the money for no appreciable gain. Medical insurance, these authors say, discourages individuals from economizing in healthcare decisions. Medical insurance incentivizes the adoption and overconsumption of medical goods that have diminishing returns on investment. So we're experiencing a kind of medical care cost ratchet. That is, we're getting more and more gadgets, we're getting more technology in medicine, which ostensibly would improve medical outcomes. I mean, how can it be a bad thing to have more MRI machines? How can it be a bad thing to have the latest, greatest technology? But in fact, if it's not enough of a gain over an earlier technology, then it may not actually be worthwhile. And that's part of the problem. So technology has driven up costs in some cases out of proportion to the improvement in care that the technology aims to deliver. You can overspend on medical diagnostic devices, treatments, and so forth. So medical researchers and drug makers in this McKinsey Quarterly article have been, as the authors say, devoting more of their energy to finding cures for diseases that affect smaller populations. You're spending a lot of money chasing something that is not as adverse a health risk as something else. The money might be better spent in other areas. One of the problems that I mentioned early on was this expansion of health insurance due to the increased payment of employees through benefits like health insurance. And as a result of this, we've seen another tier of institutions, medical insurance companies, and then later government itself, interposing itself between the patient and the care provider. So the care provider responds rationally by trying to work for the benefit or satisfaction of the third-party payer or the regulator rather than working directly for the patient. As a result of this increase in third-party payment for medical care, we see an increase in costs because patients have become poorer shoppers. They're not worried as much about the expense of something because someone else is footing the bill. This is that moral hazard concept that we mentioned earlier. If somebody else is paying the bill, you don't look at the price tag as carefully. You may not even look at it at all. A number of years ago, I had a back problem, so I went to a medical professional about this back problem. He said, well, I'd like you to get an MRI. Well, I'd never had an MRI before, so I said, fine. I scheduled a visit with an MRI provider in my area. They were able to get me in, I think, the next day or two, not much time, compared to some countries where it would take quite a bit of time to get that kind of diagnostic procedure arranged. But anyway, I showed up at the MRI place, got the test done. The images went to the doctor, and he used those in my treatment. I did not even look at the price of the MRI. I knew that I had health insurance that would cover this MRI test, and that's all that I needed to know. I looked at the bill later, and I found that the nominal price of the MRI, the price that was billed to the insurance company, was thousands and thousands of dollars. My part of that was, well, my deductible. I don't remember what my deductible was at the time, but it was very low. And I might have even already satisfied my deductible for the year. So I had a small payment, but because I didn't really have to pay most of the cost of the MRI, I didn't really care much about the overall price. That is a small example of the kind of thing that can be caused by third-party payers. If you are not paying the bill for something, you don't care as much about the cost. This chart shows medical care in general 118% higher in 2012 than it was in 1992. If you look at physician services, they're 92% higher than they were 2 decades prior. Inflation as a whole went up only 64% over that time period. But look at the purple line at the bottom of the graph. cosmetic services only went up by 30% over that 2-decade period. Cosmetic services are typically not insurance paid. Your insurance company is not going to pay for Botox or some cosmetic surgery. This is considered optional. It's not considered medically necessary, and so insurance companies don't pay for it. As a result, you're looking at a case where the third-party payer is largely absent. And as a result, prices have not risen as much. So I referred to the medical provider trying to satisfy the desires and the standards of the intermediary rather than directly working for the patient. So we have the patient wants something from the care provider, wants to feel better, wants to have a higher quality of life. We have the patient also exerting some loose influence over employers. So the employer can decide which insurance company will be used for their employees. The patient also has some very limited influence over government through voting. And government and insurance companies end up being the loudest voices for the care provider. The government's regulating the care provider, as we've already seen. The insurance company has efficiency standards that are being imposed on the care provider. The care provider, the doctor, the nurse practitioner, whoever it is that's providing the medical care, is then more concerned with making sure that they don't lose their license to the government, that they don't fall afoul of the insurance company that is paying most of the bill, and the patient's voice, the patient's standards get kind of lost in the shuffle frequently. 45 to 50% of the dollars going to care providers come from governments. About 40% come from insurance companies. Patients, only about 10 to 15%. These percentages have changed a little bit over the years, more recently, but at one point, if you go back to a period prior to, say, 1943, you'd have the patient paying most of the bill. While it may sound that this is not, may sound like this is not feasible for patients who don't have the money to pay for medical services, we have to remember that the medical service prices were also a lot lower. Medical services prices have increased as insurance and government have been paying larger fractions of the bill. We have seen more recently the same kind of thing happening with student loan availability and tuition at universities. And we've seen that as third parties have paid more and more of the bill for tuition, we've seen tuition rise almost in lockstep with that price. So the same thing's happening in medical care. You get a third party involved, and not only do the patients' voices get lost in the noise of regulation and the information coming or mandates coming from insurance companies, but the doctor is going to tend to pay attention to where the money's coming from. At the end of the day, the doctor is there to have a career, to get paid, to provide for the doctor's family, and to pay the doctor's own bills. So at the end of the day, the doctor, the nurse practitioner, is going to be incentivized to pay most attention to where the dollars are coming from. And that's not the patient as much anymore. With the ACA, we end up with a much more complicated kind of framework for providing medical care. And as we've seen challenges to this legislation, I think we've seen some improvement. But the original way this was set up, you had the patient getting even more lost in the bureaucracy. So the patient was being taxed, subsidized to some extent. There was the mandate from the federal government to the patient to have insurance. Federal government mandated the employers to provide insurance. There were the state exchanges, the federal exchanges for insurance. And all of this complexity led to even more regulation, more bureaucracy, and ultimately, for many people, higher costs as a result. Not direct costs paid directly to the care provider, but costs for insurance. We've discussed moral hazard at several points in this course, and I wanted to give you a definition of this. It's the risk or hazard that the insured party might engage in activities that are undesirable. We use that term immoral, although we don't mean it in the way we conventionally mean it. Undesirable from the insurer's point of view because they make it more likely that the claims will be larger. So if we're looking at a typical supply and demand diagram for healthcare, we see the price on the vertical axis there, the quantity of medical care on the horizontal axis. And typically what we would expect to see is a price of medical care that corresponds to that intersection there between the supply and the demand curves. What you have when a third party pays is that the price drops closer to zero. The quantity demanded by the patient at a price of zero will be about where that arrow is on the right end of the horizontal axis. So you see patients wanting a much larger quantity of medical care if they're not having to pay for it. In my case with the MRI that I had done, if I had to pay out of pocket for that MRI, first of all, the price would likely not have been several $1,000s as the price was when a third party was paying. The price would likely have been much lower if third parties were out of the picture. Secondly, I would have, if I found the price to be higher than I was willing to pay, I might have gone back to the doctor and said, look, my back pain is uncomfortable, I'm worried about it, but it's not worth the MRI to get this addressed with me. Is it possible that perhaps a cheaper diagnostic procedure, maybe an X-ray, might give you enough information? If that gives you, 80, 90% of what you would need to know to treat me, then I would accept that in exchange for having a $100 or $200 diagnostic test instead of one that's several $1,000s. So again, we have to think about that technology. Is the technology really worthwhile? If you're getting an improvement, but you're ignoring the price, then this is not the path toward efficient provision of medical care. So I don't know exactly what the difference would be in the doctor's ability to treat me if the doctor's looking at an MRI versus an X-ray. But I can say that if it's even remotely close, then I would say, look, if I'm having to pay this out of pocket, please just use the cheaper procedure or cheaper diagnostic technique. That would be my approach. Other people would say, well, this is such a difficult condition to live with. I'm really suffering here. If I get even a 5% improvement in the probability of getting better because you're using a more expensive test, then I'm willing to pay. But the current system we have does not incentivize people to make those kinds of decisions for themselves. It is a third party, after all, who's footing the bill. So if my desire for the improved effectiveness of the MRI versus an alternative is strong enough, then I would be willing to pay the bill. But if a third party is paying that, then I don't care as much. And that's just a recipe for higher costs and not very significant improvement in human health. One of the policy alternatives that's gotten some attention lately, and it's been around for a long time, but there's been a resurgence of interest and possibly some new legislation on this, is the health savings account or health savings account plan. And what this does is match or pair a health savings account, which is basically a savings account or checking account really, with a high deductible insurance policy. And many of our medical costs would be smaller costs that could come out of that kind of savings account. The truly catastrophic medical events would be paid for out of that high deductible insurance. Because it's high deductible, it is less expensive. So employers will, if they're offering this kind of plan for employees, provide the high deductible insurance at relatively low cost and sometimes make a contribution to this HSA or health savings account as well. So it's a tax-favored account. Your deposits into that would be tax deductible. The growth in that account, much like a Roth IRA, would be tax deferred. And then if you have a health expense that comes out of that account, then it's tax-free. There are limits on what those eligible expenses are, but in essence, it allows people to pay for a lot of their medical costs out of this tax-favored system. It's more likely for this to result in efficient medical cost management because the individual is able to retain whatever money is not spent out of that account. If you reach retirement age, that health savings account essentially converts to another kind of retirement account. So you are the residual claimant. You're the person who gets to keep whatever is not spent. It's very different from an insurance plan where you pay in every month, or your employer pays in every month, or both, into this insurance plan, and if you don't spend any money out of the insurance plan, then you don't keep it. The money's gone as far as you're concerned. So it's a use it or lose it kind of situation, not as likely to generate careful consideration of the costs and benefits of various medical procedures. So a health savings account turns that around and it says, look, if you're careful with your medical expenses and you use these medical procedures judiciously and you ask the appropriate questions of your doctor when your doctor says you need a certain test, if you take the time to become more informed about your health and what the advantages and disadvantages are of various routes that you could take, you get to enjoy any of the benefits of that efficiency. You get to enjoy the benefits of having saved money for a procedure that wasn't really going to give you the benefit that it would have cost you. So it serves the purpose of protecting people from the financial shock of a really big medical bill, but at the same time gives people more of the incentives that you would see in a direct pay system, where the individual is paying the medical provider directly instead of going through an insurance company. There's some streamlining in this as well. Money coming out of a health savings account is essentially like cash to a medical provider. So it avoids a lot of the expense for the medical provider in filing an insurance claim. A lot of small insurance claims can translate into an additional salaried position for a medical practice. That's pretty expensive for a medical practice. So the providers of medical care can also save on that end of things. Whether it's this policy or some other, I think that the key here in trying to understand how to improve our medical system in the United States, how to reduce the costs of medical care, this is going to center on putting responsibility and accountability back in the hands of the patient and taking that third-party payer out of the system as much as possible. It won't be completely possible. I think that there is a role for insurance, but the problem with having insurance with low deductibles, as we've become accustomed to in the United States, is that it generates this massive inefficiency. I think that there are multiple ways, not just with the HSAs, but many ways we could try to avoid those high costs in the future. Whether we see this taking place rapidly, whether we see some kind of new policy proposal come out that will put the patient back in charge, put the patient in the driver's seat of their own health care, I don't know. But I'm hopeful with the recent changes that we've seen to HSAs and to some extent with insurance that we might see more of that in the future, that we might see a move in the right direction.